see the slides there?
Yes.
Okay. So I want us to proceed. Now, I'm starting from the start just to make a confirmation from your reading. That's why I gave you time to do this on your own and see how much you can summarize. So I would like to hear from you, what are the major classes of drugs when we talk about parasympathetic? The parasympathetic branch of the autonomic nervous system, we said it works through the neurotransmitter. Which one?
Acetylcholine.
So broadly, we have drugs that promote the effect of acetylcholine at the effector sites, and there are drugs that block acetylcholine effects at the effector sites. What are the broad classes of drugs under the parasympathetic branch? I would just like a listing. No details, no mode of action whatsoever, just a listing first of all. What are the major types of drugs under parasympathetic stimulation? Hisa?
Ganglion block drugs.
Make a full listing. Make a full listing of the drugs that are under the parasympathetic, both for and against.
Cholinergic agonists.
Yeah, just do a full listing.
Muscarinic.
Cholinergic agonist.
Muscarinic. And acetylcholinesterase inhibitors.
You mentioned there for how many? Repeat, just saying one.
One, cholinergic agonist. 2, muscarinic agonist. 3, acetylcholinesterase inhibitors.
I said both for and against, so that is one side. The other side of against
ganglion block drugs. And then neurotransmitters.
Yes.
And then number 3, drugs that act presynaptically. Then number 4, drugs that inhibit cholinesterase.
Okay, is there a difference between cholinergics and muscarinic drugs? Stephen, is there a difference? Okay, you've got to reread that part and make that summary more precisely. Let's revise the slides. Muscarinic agonists, we said they are also called parasympathomimetics. In other words, they mimic the effects of parasympathetic stimulation. And therefore, the effects of acetylcholine on the sites, on the effector sites, these drugs will produce the same effects as though it's acetylcholine in action. And we did mention several examples there. Are you able to see the slides as I'm talking?
Yes.
Okay. we have the bethanical, which we mentioned, and pilocarpine, that are the ones that are more useful clinically. I'll not repeat the effects of muscarinic agonists because we already know from what we studied on parasympathetic actions. But I'll be particular for you to give me the side effects at the end of it all. I had asked you to do a mnemonic, so I would be expecting the mnemonic. Then muscarinic antagonists or parasympatholytic drugs. These as well can be called anticholinergic drugs. And I had given these examples of atropine, hyoscine, ipratropium, among the list as those that are very useful clinically. I had asked you to do drug cards on those three. In which two clinical situations do we apply atropine?
Bradycardia.
Bradycardia and Edel?
During like antidote for overdose of cholinergic drugs.
Overdose of?
Cholinergic drugs.
Like which ones? I was very particular yesterday. Crispin?
So, according to me, I think atropine clinical uses is during surgery. Actually, it is used as an anesthetic pre-med. Yeah.
What was the purpose? What was the indication for us to use atropine as a premedication before a surgical operation?
Actually, to prevent vomiting, which may cause actually choking. Yeah.
Oh.
Like that.
Prevent vomiting, it limits production of secretions. And in terms of poisoning, which particular drugs or poisons did I mention yesterday that atropine may be used? And in fact, I said we atropinize, we give it very frequently.
Organophosphate.
Organophosphate poisoning, okay. That's what I was waiting to hear. Now, how does ipratropium help in relief of asthmatic symptoms?
It blocks acetylcholine receptors, and we know that acetylcholine causes bronchoconstriction. So by blocking, it prevents bronchoconstriction and promotes bronchodilation. Hence, the airway is open.
Very good. That's how beneficial it is in asthmatic cases. Okay, we have another drug there called hyoscine or buscopan. I said that we apply it in which two clinical situations? At least two. There are many, but I just want two now.
Cramps.
Okay. And?
Ulcers.
Okay, very well. Now, there's a third drug that I didn't mention there, but I would like you to look for it under that class called scopolamine. 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 Look for a drug called scopolamine and its uses in motion sickness. Do you know what motion sickness is? There are people who can't stand movement in a vehicle. They will vomit a lot. That's what we call motion sickness. So there are certain drugs that people can take prior to traveling to assist them not to vomit. And that scopolamine is one of them. Okay, fine. Let's proceed with the slides. Effect of muscarinic antagonists. I will not take a lot of time there again. Drugs affecting autonomic ganglia. Now, these drugs that affect autonomic ganglia, for them to block acetylcholine, how do they work? Like, how does nicotine become an acetylcholine blocker? Yet we know that acetylcholine works on nicotinic receptors. How does nicotine become an acetylcholine blocker, whereas we know? Yes, Edel?
I think by interfering with the binding of acetylcholine to its receptors.
Very well. They are going, it is actually like a competitive antagonist. Once it binds to receptors, acetylcholine has nowhere to bind, and therefore it will not excite the effector tissues ahead. Very good. So that's how a ganglion stimulant like nicotine work in terms of being blockade anticholinergic drugs. Okay. We have another class of drugs that we call neuromuscular blocking agents. There are two main types, non-depolarizing and depolarizing. What are the examples? The non-depolarizing, we have such drugs as pancronium, atracurium, vegronium, tibocuranin, etc. What is their mode of action? They are competitive antagonists at the acetylcholine receptors of the end plate. Where is the end plate? We know what the motor end plate is. We know where the end plate is. Oma.
Okay, an end plate
refers to.
Okay, an end plate I think is just a specialized region of muscle, maybe something to do with muscle, and where a synapse is formed with a motor neuron.
Yeah.
Yeah.
Right,
Rudia tu vizuri kama umetulia.
okay, I'm saying that it's a region of muscle fibers membrane where it forms a synapse with a motor neuron.
Okay. Good. So, and that's why I'm asking you to do lots of practice in reading and trying to commit these things to memory, because they are rather obvious, but when you start articulating, unaona ni kama inapotea potea. Okay, so we have said they competitively antagonize acetylcholine receptors at the end plate. In other words, where the motor neuron joins the muscle fibers. And with that, acetylcholine will not have an effect. Okay. Next. I'm looking for the depolarizing ones. The depolarizing ones still, they work just like we have just said for the non-depolarizing, but they have a small difference. What's the difference between the two? What's the difference between the depolarizing and the non-depolarizing? In other words, the only message here I want to say is what is to depolarize a cell? What is to depolarize a cell? Crispin?
So to depolarize a cell, I think is when the inside of the cell become positively charged and outside of the cell become negatively charged.
So there is an action potential, in short.
Yeah, where sodium ions enter the cell, making it inside to be positively charged and outside becomes negatively charged.
Okay.
Yeah.
So that's good. So there are those depolarizing ones that cause action potential, and there are non-depolarizing ones that do not cause an action potential. Fine, let's move forward. And we have seen the examples there of the depolarizing ones: suxamethonium, decamethonium, etc. And we are told that in terms of clinical application, it is mainly suxamethonium that we are using often. So that's a drug I would want to ask you to take very serious note of. Then we have drugs that act presynaptically. Drugs that act presynaptically. How does the neurotransmitter cross from the fibers that are bringing it to the fibers that are going to cause the effect? How does the neurotransmitter move? In other words, how does the neurotransmitter cross the synapse? Yes, Crispin?
I think through diffusion.
Through?
Diffusion.
See, diffusion meaning like it moves from a region of high concentration to a region of low concentration.
Yes.
How does it move?
Okay, it's through diffusion, but yes, it's from high concentration where the high concentration ni penye the presynaptic terminal to an area of low concentration, the postsynaptic neuron.
Okay, so both of you are right. It is just that I needed you to affirm your response. Yeah, where it is coming from, the concentration is higher than where it's going, and therefore, once it's released, it will be plenty within the synapse, and therefore it will diffuse to the post synapse fiber. Okay, good. So what are the examples of the drugs that act presynaptically? When they do so, therefore, they block the release of acetylcholine. If it's not released, it's not going to cross the synapse, and therefore it's not going to transmit the message. Examples are hemicolinium, triethylcholine, vesamicol, etc. We also have some drugs that are not necessarily in this class. They actually have their other beneficial effects in other areas, but they happen to have these effects of blocking acetylcholine release. And for example, the one that I've mentioned there is aminoglycoside antibiotics. Has any of you come across a drug by the name gentamicin by any chance, whether in the ward or even in your own needs? A drug gentamicin. Anyone? So it is one of the most outstanding aminoglycosides. It is an antibacterial drug. Talking about aminoglycosides, that their benefits are quite apart from what we have presented here. This just happens to be an inadvertent finding, that they are very good antibacterial agents that inhibit protein synthesis in the bacteria and make it die. But they have also been found to possibly cause some paralysis by inhibiting acetylcholine release presynaptically. Okay, so let's move on. How about those ones that enhance cholinergic transmission? And then we have those that inhibit cholinesterase. Okay, that's what I wanted to talk about. When we inhibit cholinesterase, what is the effect of inhibiting cholinesterase? What is the effect of inhibiting cholinesterase?
So acetylcholine will not be synthesized because cholinesterase is the one that synthesizes acetylcholine.
Do we agree with it? Anybody else with a different version? Cholinesterase, is it the one that synthesizes acetylcholine? Precious, you wanted to say something?
I think cholinesterase is the one that pardon?
Okay, what is the job of cholinesterase?
Cholinesterase breaks down as acetylcholine.
It breaks down acetylcholine, isn't it? So if it does so, if cholinesterase is in plenty, then what happens to acetylcholine?
It will decrease.
Because it will be broken down faster.
Yes.
It will be metabolized faster. Very well. Now, what are we talking about these drugs? They are called cholinesterase inhibitors. Cholinesterase inhibitors. If we inhibit the enzyme that breaks down acetylcholine, then what happens to the amount of acetylcholine?
They increase.
It will increase. Okay. So in effect, we'll be promoting some acetylcholine effects because we are reducing its metabolism. We are making much more acetylcholine available for effecting. And we have examples: edrophonium, neostigmine, physostigmine, etc. We have the reversible ones and the irreversible ones. The irreversible ones are dangerous, actually. When that kind of excitation happens, then we'll end up with paralysis. And that means such a drug is actually a poison. So the irreversible ones like ecothiopate, parathion, and we have another one called malathion. Indeed, those are poisons because of that irreversible effects on on cholinesterase. So they will actually cause a paralysis. And therefore, in human beings, we rarely use them, but they can be very good in use as insecticides. They'll be able to kill. Okay, effects of anticholinesterase drugs, enhanced activity. Okay, I will not go into the effects of parasympathetic effects and sympathetic effects. I'll just go straight to the drugs alone. Clinical uses of anticholinesterase. That's the best, the benefit that we wanted to look at. In anesthesia, a drug like neostigmine has been found to reverse the action of non-depolarizing neuromuscular blocking drugs. In myasthenia gravis, a drug like pyridostigmine has been found to have an advantage. Now, what is myasthenia gravis in the first place? What is myasthenia gravis?
It's a weakness and rapid fatigue of muscles under voluntary control.
Okay, weakness. And why would the weakness be?
I think it's caused by a breakdown in communication between nerves and muscles.
Okay. So we had said that oral neostigmine has been found to be of benefit in people with myasthenia gravis. Okay, let's move on. Edrophonium, all those you will read. Right now, I'm only going into the classifications and examples. Adrenergic system drugs. Adrenergic system drugs. May I have a listing of the whole possibility of the classifications of adrenergic system drugs. Just make a list of adrenergic system drugs, those that promote adrenergic activity and those that block adrenergic activity. Adele, your hand is up, kindly.
So those that promote alpha-1 agonist, alpha-2 agonist, beta-1 agonist, beta-2 agonist, then non-selective agonist, then those that block alpha-1 blockers, beta-1 blockers, I think those are cardioselective. Then beta-2 blockers, those are non-selective. Then adrenergic neuron blockers. Yeah.
Okay. So when we block, when we promote adrenergic activity, effectively we are promoting effects of sympathetic stimulation. And once we just remember the effects of sympathetic stimulation, then it becomes quite easy and straightforward because we know what sympathetic does. I had mentioned key organs that we can always use to remember in terms of trying to know how sympathetic works. What are the effects of sympathetic on the pupils of the eye? What are the effects on the heart? What are the effects on the airways? What are the effects on the GIT? What are the effects on the kidneys? What are the effects on the bladder? What are the effects on the sphincters? What are the effects on sexual activity? We remember that yesterday, isn't it? Okay. So when you give a drug that promotes sympathetic activity, then you just effectively are actually exciting sympathetic. When we give a drug that antagonizes sympathetic activity, we are simply putting down sympathetic and therefore allowing parasympathetic effects in a way. But to get more particular, we need to know which receptors are abundant where. Which receptors are abundant where. Alpha 1 and 2 are abundant in which areas? Where are the alpha receptors more distributed?
Blood vessels.
Blood vessels, okay. That is alpha 1 or alpha 2?
Both alpha 1 and alpha 2.
Okay, both alpha 1 and alpha 2. How about beta 1? Where is it more concentrated?
In the heart.
Okay. Beta 2?
Bronchi.
The bronchi. And where else?
Kidney.
Okay, actually the rest of the smooth muscles. And then beta 3 is more abundant where?
Adipose.
In adipose tissue. Okay. Fine. So knowing that is quite important because we have drugs that are selective on whatever receptors they work on. And when we know which drugs are working on which receptors, then we know clearly where they are likely to have the effect. If a drug is working on alpha 1, it's likely to have an effect where? When a drug works on alpha 1 receptors, where is it going to have an effect? Okay, Crispin?
So according to me, if most of alpha 1 receptors are found on the blood vessel, then that drug will have effect on the blood vessels.
Very well. What is the effect of sympathetic stimulation of the blood vessels?
Vasoconstrict.
vasoconstrict. Now, which physiological dynamics will therefore a drug that works on the alpha-1 receptors affect? What physiological dynamics will a drug that works on alpha-1 receptors affect? In other words, when blood vessels dynamics alter, what physiological dynamics get altered?
Yeah, it's the answer.
The blood pressure will increase.
Yes. When they constrict, the pressure will increase. When they dilate, the pressure will drop.
Yeah.
Okay. Next, if a drug works on alpha-2 receptors, what physiological dynamics are likely to be affected? If a drug works on alpha-2 adrenergic receptors, what physiological dynamics or parameters are likely to be affected? Because we have said alpha-2 receptors equally are found on the blood vessels and in the platelets. So then the effect will be still on the blood pressure. When a drug works on beta-1 receptors, which physiological dynamics are going to be affected? Yes, which dynamics are going to be affected?
Blood pressure.
Yes, that is one, because beta-1 receptors are burdened where?
The heart.
In the heart. So you look at the effects of sympathetic stimulation on the heart. The heart rate will be affected, the cardiac output will be affected, and blood pressure will be affected. It depends on the effects as to whether it is sympathetic stimulation or beta-1 stimulation or beta-1 inhibition. Next, when a drug works on beta-2 receptors, what are the physiological dynamics that are likely to be affected?
Respiration.
Because beta-2 receptors are burdened where?
In smooth muscles.
In the smooth muscles generally and in the airways. So look at the airways. It's going to affect airway patency, depending on the effect, whether it's inhibition or it is stimulation. On the smooth muscles like the GIT, the kidneys, the bladder, and so forth, depending on the effect, whether stimulation or inhibition, those dynamics are the ones that are going to be affected. When a drug works on beta-3 receptors, what physiological parameters are likely to be affected? We said beta-3 is plenty where?
Adipose tissue.
Adipose tissue. How do we end up with adipose tissue? How does adipose tissue come about? Like how do we accumulate adipose tissue?
Accumulation of lipids.
Yeah, see, other materials that are not spliceable are the ones that are stored as fat. What happens in times when the demand increases more than what we are taking in terms of nutrients? Si mtu anakonda, because then there will be fat breakdown.
Yeah.
Okay. So fine, now we've gone through the full drill. Once you know the physiological effects of stimulation of either receptors, then for the drugs, all you want to know is just the classification and the examples. Because the effects will already be the physiological effects that you are either blocking or stimulating. run through again the examples. Adrenergic transmission, we know what it is, and the neurotransmitter. Now, endogenous catecholamines, we have seen epinephrine, which is a potent stimulator of both alpha and beta adrenergic receptors. What will be the effects? An increase in blood pressure. An increase in blood pressure. On the heart, direct myocardial stimulation, inotropic action and chronotropic action. Let's clarify. What's the difference between chronotropic and inotropic actions? What is it that we call inotropic? What is it that we call chronotropic?
So chronotropic, I think, is the rate at which the heart beats.
Yes.
While inotropic refers to the force of contraction of the heart muscle.
Okay. So when an agent is inotropic, it means it increases the force with which the heart beats. Then if it's chronotropic, it increases the rate. In this case, epinephrine is both inotropic as well as chronotropic. When we will study drugs that work on the heart per se under cardiovascular system, there's a drug like what we call digoxin that increases the force of heartbeat without increasing the rate. So that is an agent that is only inotropic and having no chronotropic effects. Okay, so a drug like epinephrine is a direct acting sympathomimetic drug. Therefore, what will be the effect of epinephrine on the heart? It will increase the heart rate, and therefore, consequently, it will increase the blood pressure. How does the heart rate increases the blood pressure? We know the equation for blood pressure being a function of cardiac output and peripheral resistance. And cardiac output is a function of heart rate and stroke volume. What is stroke volume? Uma, Stephen?
Stroke volume, I think, is the amount of. You don't think.
Yeah, umeanza vizuri, endelea.
Okay, stroke volume, I think, is the amount of blood ejected by the left ventricle of the heart in one athlete.
At every contraction, okay? How many contractions are there roughly in a minute? In other words, what's the average heart rate in a minute? Or pulse rate in a minute? For a normal adult?
60 to 100.
60 to 100 is the range. On
I
average,
think
is about
72.
72. Okay, how much is the cardiac output? How much is the cardiac output for a normal adult? We assume an average adult to be weighing 70 kgs. How much is the cardiac output? About how many liters?
About 5 to 6 liters per minute.
Okay, how do we how do we go about getting the 5 liters or so?
So I think that we take the heart rate by stroke volume.
Okay, that is it. So 70 ml is what is usually ejected. What's the stroke volume? It's assumed that the heart gives out about 70 ml per ejection, because the volume of the heart itself is around 120 mLs. And at every ejection, it has been measured and been found that about 50 remains. So how much went out is just 70. Times 72, you get 50/40. Divide by 1,000, you get 5.04 liters. Okay, let's move forward. And that is why once you know the physiology, the drugs are very simple. Now, what are the beneficial effects of epinephrine? What are the clinical applications in which we can use epinephrine? We can actually use epinephrine, especially if there's airway obstruction. It has been very effective. We use it to nebulize when people are having narrowing of the airway. And when we are doing that, and especially in asthmatic or allergic reactions, we are doing that via which receptors?
Beta-2.
Beta-2 receptors. It's actually very effective. You nebulize somebody, and in 15 to 25 minutes or so, you get the beneficial effects. It is very important in anaphylactic reactions. It antagonizes functionally antagonizes the effect of histamine on the bronchial walls. The effect of histamine is to narrow the airway, because histamine is the chemical released during hypersensitivity reactions. Adrenaline or epinephrine does not necessarily bind on the same receptors as histamine. It works on different receptors, but functionally antagonizes the narrowing effects of histamine on the bronchial airways. This is a drug that we have also found very beneficial. In fact, recently in the hospital, I had a case of somebody who was reacting to a drug. This person was reacting to one of the antihypertensive drugs called enalapril. And the side effect of enalapril was what we call angioedema. Now, it was coming through the buccal cavity. Now you can imagine what angioedema means and how that will change the buccal cavity. In angioedema, the blood vessels dilate massively. So there will be a lot of tissue fluid. Mdomo itafanya aje?
It will have secretions.
Si kwa mdomo, as in the oral tissue, not necessarily kwa mdomo. It's the tissues that form the oral cavity. So it's the vessels within the buccal muscles. So what will happen to those tissues? There will be massive swelling. And due to it, mtu alikuja mdomo inafura ikiendelea rapidly. When we gave adrenaline,